are going to be discussing the case study of a 20-year-old female collegiate athlete who is a soccer player and sustained an injury during a game yesterday to her left ankle. Upon taking a history, we have discovered that the mechanism of injury occurred at which point in time where she was turning and the opponent came up and tried to steal the ball. She thinks she heard a pop and that she felt a force maybe from the side or the front of her ankle. She can't really remember. It was the end of the game, and she did play through it, but it was only for about 2 minutes, and then she was having issues walking after. She is sustained edema to the anterior lateral aspect of the ankle, but it is not severe edema. And she also describes the pain as being localized and sort of just throbbing and a lot of discomfort. She has said that she had a lateral ankle sprain to the left ankle, which is the same ankle that was injured yesterday, 6 months ago, but she has returned fully to play and is fully recovered, and everything is back to normal. She also sustained an injury, a lateral ankle sprain to her left ankle when she was 13 and when she was 16 years old. She was using compression and elevation and ice post-game yesterday, post-injury, to help take care of this, and she thought that paired with an NSAID would help alleviate the symptoms, as it has in the past for her lateral ankle sprains, but she's having difficulty walking. It's been about 24 hours since her injury was sustained, and she has not had any NSAID since yesterday evening. She has not taken anything else for the pain, and she did enter on crutches. So as we start to assess the patient, we are going to want to see if she is fully weight bearing or fully unable to bear weight, as well as start to think about different conditions that could be affecting her. Since she has a history of lateral ankle sprain, we want to think about an ankle sprain paired with the pain and the edema. And so we know that lateral ankle sprains, or ankle sprains in general, predispose people to a higher risk of sustaining one in the future. We also want to rule out fractures, since she is saying she is having a difficult time bearing weight. So specifically, we can think of maybe a fracture of the tibia, fibula, or the talus. And then we also want to rule out compartment syndrome, or anything that might be causing any sort of nerve compression, which could be making it difficult for her to bear weight. She also has reported a loss of function in her foot, her inability to fully plantar or dorsiflex. And one reason she's taken to the crutches is because she is having a very difficult time walking up and down the stairs, which is where she would be having so much more difficulty with the plantar and dorsiflexion. Start off our palpations by comparing, making sure that we compare the affected side to the non-affected side. So just always a rule of thumb with palpations and testing, we want to test the affected side versus the non-affected side. And we can just start pretty much anywhere, but we do want to think about the structures that are important to us and things that we've considered. So right now we've considered a lateral ankle sprain, a medial ankle sprain, fracture of the tibia, fibula, or talus, compartment syndrome, or even a high ankle sprain at this point. So we can start off by just going medial, and we'll just feel around the deltoid ligaments and palpating those. She doesn't feel any point tenderness, and they feel similar to they feel very comparable to the ligaments of her non-affected, her right leg. We can just start to make our way more interior. We have found the talus at this point, and she said that she is feeling some pain on her left side there and tenderness. This is also the area that we are finding the edema. And then we'll make our way up to the anterior tibiofibular ligament. And she said that's where she's really feeling a lot of pain. We can feel a little bit of laxity in that ligament as well, or it feels like something is not where it should B as we start to palpate the opposite side. And so we are feeling a major structural difference from those two. We can start to make our way down to the anterior tibiofibular or talofibular ligament and then the calcaneofibular ligament. And she is feeling a little bit of pain, but again, this is where she is having the edema, but it is much, much more severe on the anterior tibiofibular ligament than the anterior talofibular ligament. And then she is feeling nothing with the calcaneofibular ligament. We also want to think about just doing checking for the dorsal pedal pulse as we start to think about compartment syndrome, which is equally present on both sides. And also we can just test her deep perineal dermatome, which she does feel, and she feels her superficial perineal. So we're beginning to think less of nerve entrapment or compartment syndrome and more of a structural issue, maybe a lateral or high ankle sprain. We do want to have her walk 4 steps. But first we'll just go ahead and start the Ottawa ankle rules. So we're going to just palpate around the medial and lateral malleoli, and then we're also going to palpate the navicular and the base of the fifth, and both of those are fine, and compare, and everything feels normal. So then we'll have her just do 4 steps and see if she can bear weight. And she's having a hard time moving the ankle as she walks. And she also is walking gingerly. So she right now is not showing that she has a fracture, but we can do a percussion test and a POTS compression test just to double check. So we can start by doing the percussion test. In a perfect world, the patient would be laying flat, and the clinician would take the foot to dorsiflexion and then take the heel of the hand to the calcaneus. And she did not feel anything out of the ordinary for that. We do the same on the contralateral side. And then starting to do the POTS compression test, you're going to start proximally at the fibula and the tibia, and then just start to work your way down the leg. And she did not feel any pain with that one. We'll test on the other side, and everything was normal. She tested negative for both of those. So now we want to start to think about doing some strength tests and range of motion tests. So on her contralateral side, we can look at what her full range of motion is, and typically we would just compare these bilaterally as we go through each motion, but for the sake of time, I'm going to go ahead and show you what these range of motions are going to look like. So active range of motion, she's going to have about 15 to 20 degrees of active dorsiflexion, active plantar flexion, and then for inversion and eversion, she's going to have full inversion and eversion. And then as we come into these on the affected side, we are going to notice that for the inversion, she has a little bit of limited range of motion. Again, we do have pain and edema in the anterior lateral aspect of the ankle, so that could be starting to limit that. And then so we'll just go ahead and take her through the Taylor tilt test, stressing the anterior talofibular ligament and the calcaneofibular ligament. And she is feeling discomfort, but she's not feeling any specific pain coming from those structures. So let's just know that those are still intact. And then we can go ahead and just take her through a strength test. So she'll go into inversion for 1, 2, 3, 4, 5. And then we'll just go ahead and do a break test. So she'll come into inversion and then try to resist me. 1, 2, 3, 4, 5. And she did fine with that one. So we're beginning to think, okay, maybe not a lateral ankle sprain. do the same for the medial. We don't think it's a medial ankle sprain at this point, but we can start to take her into that lateral talar tilt test, and this is going to stress the deltoid ligaments. She's not feeling anything there. And then we'll just take her through a strength test. So as she comes into eversion, I'm just going to apply some pressure for 1, 2, 3, 4, 5, and she did fine with that. And then for her break test, she is 2, 3, 4, 5, and she did have some issue with resistance for both of the lateral and the medial, but they were pretty okay, and she didn't have a lot of pain coming from her deltoid ligaments or her talofibular ligament or calcaneofibular ligament, which helps us to start to rule out that maybe it's just a surrounding structure and there is a lot of inflammation in that area. So as we come into plantar flexion, we're going to notice that her plantar flexion is limited, and passively, actively, we can only get to about here. Passively, we're only taking her, we're taking her short of her full plantar flexion. And she is going to feel pain across the top of the foot. She does not have any burning nerve pain though, as we put her through that, so we do know that we're not so much looking again at nerve entrapment as much as we are looking at a structural damage. So as we take her through a strength test, she's really having issues with the amount of pressure that I'm putting on her. And then for a break test, she just comes right out of plantar flexion. So she has lost her ability of function with plantar flexion. And we're gonna actually see the same thing with dorsiflexion. So her passive dorsiflexion is really only at neutral, where on her contralateral limb, she can get into about 20 degrees of passive dorsiflexion. And then as we come into our strength test, 4, 5, she's having a really hard time with the resistance. And then the break test, she just comes right out of it. So then the next things we want to start doing is we're thinking not so much lateral ankle sprain, definitely not medial ankle sprain, but we are starting to think of a high ankle sprain at this point. She does have anterior lateral edema. Her anterior tibiofibular ligament is not feeling like it's intact, and she doesn't have enough edema for it to necessarily be a lateral ankle sprain, although she did have compression, so that could have prevented as much edema. But we are finding the structures to be more indicative. So what we can do at this point is we can do a modified Kleiger's test, which puts direct stress onto that anterior tibiofibular ligament. And we're just gonna take the foot, place it into dorsiflexion, and laterally rotate. And she does feel a lot of pain with that test. And then the next one we'll do to test for a syndesmotic separation is we're just going to do the squeeze test, where we just go to the proximal end of the tibia and fibula, and we're going to squeeze, and we're going to just see a tiny bit of movement happening that is not happening on the contralateral limb. So between those two tests, we are now able to rule in that she likely has a syndesmotic or high ankle sprain, or she does. Thank you for taking the time to listen to this video. I hope that you found it educational and informative as we went through the assessment of a high ankle sprain, or clinically known as a syndesmotic sprain.